Hello, everybody. Thank you so much for joining me today in my presentation where we dive into populations with special needs. And I took a comparative look on how the United States and France takes care of these populations or doesn't take care of them. So let's get into it. So, who are populations with special needs? Populations with special needs include individuals with physical, developmental disabilities, chronic illnesses, mental health conditions, social vulnerabilities like poverty and homelessness. These groups often require ongoing coordinated services that go beyond standard health care. Speaking from a former caseworker perspective, absolutely. um, so these groups may also be referred to as underserved population, underprivileged, vulnerable populations, marginalized groups. Essentially, they're all the same. So, like I stated previously, just some examples of populations with special needs include chronically ill humans, disabled humans, humans with HIV/AIDS, transgender humans, racial and ethnic minority humans, unhoused humans, uninsured humans, and women and children. So, to describe and study populations, special populations, a vulnerability model was crafted. So, in order to correctly attribute and speak about populations with special needs, we need to attribute their vulnerability. So, vulnerability is described as susceptibility to negative events that result in poor health or illness. So, poor health can be manifested physically, psychologically, or socially, and often these vulnerabilities intersect. If somebody is chronically disabled, they are at a greater risk of having a mental health disability as well, or a mental health condition. Vulnerability is essentially determined by three things: predisposing, enabling, and need characteristics. So we're going to get into that a little bit. So predisposing characteristics include demographics, belief systems, and social structure variables. So I listed some examples in all of these categories. So demographics is your stuff like, your race, your ethnicity, your sex, your gender identity, age, everything like that. Your belief systems, this is going to include your religious belief, as well as your health literacy and cultural practices. Cultural practices wasn't in the book, but I feel it is very relevant to belief systems. And then lastly, we have social structure variables. And those are going to be things like educational level, marital status, immigration status, as well as if somebody has been involved in the criminal justice system. Enabling characteristics are going to be your socioeconomic status, your individual assets, and your mediating factors. So, socioeconomic status, that's like your social position, your access to resources, how much money you have, how educated you are, if you have a job, where you live, everything like that. Individual assets, it's more like, generational wealth or what you have access to. Let's just say, for an example, your parent is a doctor. That is definitely an individual asset. And then we have mediating factors such as insurance and then also your quality of healthcare that you receive. And then lastly, we have need characteristics. This includes health status, whether it's, self-perceived or professionally evaluated, as well as quality of life indicators such as your physical ability, your social limitations, your cognitive limitations, and if you need any help or have the ability to perform daily tasks for life and work. So all of those combined help assess vulnerability and these populations with special needs. And keep in mind, like I stated previously, a lot of those end up intersecting in interesting and frustrating ways for these populations. So we're going to get into the U.S. healthcare system and how the U.S. Addresses these populations and marginalized groups, right? So, in this Of course, so far we've learned a lot about the U.S. healthcare system and its successes and failings. So we know that the U.S. lacks a unified healthcare system. Service and care delivery is super fragmented. It's eligibility based. There's no centralized oversight. There's limited coordination, and there is a lot of institutional care going on. Okay, so that's just a brief overview. So what I want to get into is just some different programs that I found in my research and from lived experience that support populations with special needs. So, of course, we have Medicaid, Medicare. Medicaid is eligibility and income based, and that varies by state. And Medicaid has limited care. We've all heard of, Medicaid denying this care and that care, and it can be very frustrating, especially for if specialized care is needed with specialized professionals. Then we have Medicare for elderly people or people aged 65 plus. And I didn't realize this, but people aged under 65 with disabilities can also apply for Medicare. And Medicaid and Medicare are often used in conjunction. Then we have SSDI, which is monthly income for people with disabilities. And you do have to be eligible for that program. And it can be a doozy of a program to apply for. They always say, prepare to get denied first. You have to apply a bunch of times. So then we have individuals with disability education, program for inclusive care. Please feel free to pause. I want to respect the time limits, so I have to be mindful of what I go through here. Then we have SNAP, aka food stamps, WIC, which is nutrition and breastfeeding assistance for pregnant and postpartum children. We have CHIP, which is health insurance. So yeah, that's a brief overview. Some strengths of the U.S. healthcare system, lots of community-based models, local programs help close the barriers between services, and it also focuses on person-centered care model. And also I do feel like that some of these programs address cultural needs as well. I should have put that in there. There's legal advocacy like the ADA, and then also the U.S. is improving in telehealth and mobile apps and remote monitoring, which can be really great in reducing barriers to access, especially for people who do not have transportation or who have mobility concerns in relation to a disability or otherwise. So challenges, we know that the system is fragmented. There's unequal access and systematic barriers to discrimination, including language disparities, stigma, aka racism within the healthcare system, workforce shortages and caregiver burden. Direct support professionals is a low pay, high burnout role, and really just generally underfunded systems, right? So the French healthcare system, France offers universal healthcare coverage, as they should, with central oversight. So France had a couple of programs that I referenced that do support populations with special needs. France is very progressive when it comes to disability recognition and assistance through the MDPH as well as the APA. My French isn't that great, so I will not try to pronounce those. And they do have an emphasis on home-based care, which I think is great. So some strengths of the French healthcare system is they have universal access to healthcare. All citizens are entitled, and it gives kind of a standard of service accessible, as well as financial protection for healthcare services rendered. They have coordinated system for disability support, as well as long-term based support, like I mentioned in the previous slide. Some challenges of the French healthcare system. Bureaucracy, of course, although their systems are highly organized, especially compared to the United States, it can take months to process requests. Of course, there's going to be regional disparities, like we have seen between these urban and rural locations in all of these different countries. And underserved populations still face barriers, language barriers, and then also trouble accessing a foreign system. So some improvements. What can France learn from the U.S.? I think that France can improve their community-based services, so the care can be, localized, and also remove cultural barriers. Technological access, such as telehealth and mobile apps, could definitely be improved. And then also intersectional inequalities. Like I said, while France is fairly progressive for people with disabilities. They're still struggling to serve populations like immigrants, LGBTQ people, and also people who need mental health care. Mental health care is still an emerging field that can definitely be improved upon everywhere. What can the US learn from France? Obviously, universal health care, basic rights, it standardizes the access, coordinated one stop services like the MDPH model. In France, it reduces the amount of hoops to jump through and eliminates the need for cross service communication. Formal system for caregivers and inclusion of home care services. I think this is a really, really great step in the right direction and is something that the US could quote unquote easily implement. And one thing that I find especially cool is the stipend for home modifications, because just the price to put in a wheelchair ramp for a home, for just, even if you don't put labor into it, just the cost of materials and time is inaccessible for a lot of people. So I think that could really change some lives here in the United States. And some final thoughts. I know I'm slightly over time, but please bear with me. Ultimately, vulnerable populations deserve equitable care, hands down, no questions. Equitable care requires an integration of health, social, and economic support, and a just and fair health system uplifts its most vulnerable. So thank you so much for sticking with me. I apologize that I kind of went through it fast and I stumbled through my words, but I recorded this so many times that I just had to get through it. Please let me know what questions you have, and I'm looking forward to your feedback. Thank you so much, everybody.